Hello, my name is Dolores Irwin, and I am president of the League of Women Voters of Kittitas County. The League, in cooperation with the Kittitas County Health Network, is pleased to bring you this forum about an initiative for a 0.1% increase in sales tax to fund more mental health services in the county. This additional tax amounts to 1 dime for every $100 of taxable purchases. It won't solve all our mental health problems, but is a step in the right direction. The League strongly supports this measure because mental health is a community problem, not just an individual problem. Almost all of us has a family member or friend who has suffered from addictions, mental health issues, or have committed suicide. Please listen to the experts in this video and learn more about this issue. The moderator for the forum is Rich Elliott, Deputy Fire Chief of Kittitas Valley Fire and Rescue, who manages operations, training, and prevention. Operations includes EMS, which is response, transport, and community outreach. That is how he is directly involved in behavioral and mental health access for the community. Rich?
We are going to have a conversation, albeit virtual, with our audience regarding the proposed 0.1% sales tax for behavioral and mental health services in Kittitas County. Hopefully we'll be able to answer your questions about what the tax is, what it might do for the community. And with us tonight, we have a group of subject matter experts in our community. Our panelists include Dee Dee Utley, who is the Director of Emergency Services for Kittitas Valley Hospital. We have Diane Rosso, who is the Community Prevention and Wellness Coordinator for the Ellsberg Schools. We have Greg Abel, who is the Director of Comprehensive Healthcare for Kittitas County. Oren O'Connell, who is a family psychiatric practitioner in Upper Kittitas County, and Steve Panatoni, who is the Commander Jail Superintendent for Kittitas County. Before we start, we're going to hear from each of the individual panelists, and we will give you the opportunity to interact with us through Facebook. We have a series of moderators and facilitators who are actually reading your questions and should be able to funnel them to us. If that doesn't work in lifetime, we are always available because we work for you in the community and we can follow up with answers to your questions. So before we start, we are going to have a brief overview of the presentation. This is essentially a PowerPoint presentation that we made to the Kittitas County Commissioners about 6 weeks ago now. It's actually one of a series of presentations we've made to the commissioners, but it summarizes and encompasses the efforts that your community members have been making with regards to behavioral and mental health services and access in Kittitas County. So we'll bring up the PowerPoint presentation. And so I'll begin to go ahead and just summarize. So the 0.1% sales tax initiative is authorized by the state of Washington in 2005. The state legislature and the governor signed into law, or passed and then signed into law, RCW 8214 460, which provides for mostly counties, although there is one municipality, the city of Tacoma. They can pass through councilmatic action, which basically means your county commissioners or your city council can vote by a simple majority to enact a 0.1% sales tax, which is dedicated to new or expanded services with relation to behavioral and mental health services. So you can't supplant any existing funding. These are for new or expanded services. And roughly over half of the counties, there's 39 counties, and then obviously just one municipality in the state of Washington, have actually passed this tax. You can see a map of the state, and obviously, you know, much of the western side of the state, but also you have a fair representation of the counties on the east side of the state have passed this tax. You see Kittitas County, obviously that decision is pending. And I will also just point out that our neighbors to the south just passed this in October of 2019. That would be Yakima County. So they were the latest to pass this tax. The sales tax, and this was based off of sort of not understanding what the COVID impacts would be. The sales tax would generate roughly $1 million a year for services inside Kittitas County for our community's resources. So this effort is actually the part of probably a multi-decade process. The latest effort, the latest group of participants have actually been in various forums involved in this for about the last 10 years. And roughly 3 years ago, we started noticing that we were having a lot of our community members sort of drop through the cracks. People would end up in crisis, and people in mental or behavioral health crisis end up in the emergency room. They call 911 for both law enforcement and potentially emergency medical services. And sometimes they work through the correctional system. And all four of those services in our community, they're vital services, they're core services, are overtaxed at times, and they're very expensive. And in addition to being expensive and sometimes being needed for other things, we also see that behavioral and mental health crises, or the result of chronic issues related to those things, don't necessarily get resolved by visiting any one or even all four of those different entities. So out of this effort about 3 years ago, you had stakeholders, elected officials, schools, private citizens. There were about 30 to 40 of us that were meeting quarterly. One of the initiatives we came up with was that we had to develop a way to generate some revenue at the local level that we could potentially use as leverage or investment money to compete for grant funding through the federal and state programs, so that we could increase access to services in our community and maybe deliver them a little bit more effectively. So in the summer of 2019, we formed a task force with the intent, talked to the commissioners, told them this was coming. We pulled all our data together and made a series of presentations to the county commissioners and got feedback along the way. They first saw it in November, December, and January. We saw 3 different versions. And in February, we sort of presented what we hoped would spur a willingness on their part to hold a public hearing and then potentially vote on this, yay or nay. The feedback we got was that they wanted some more detailed information about how we thought the money might be invested and what those outcomes would be. And they wanted us to continue to contact various groups in the community and make sure that everybody in the community that, could possibly, have an interest in this or be involved or affected by this, that we gave them the opportunity to have the information presented and ask questions. So we made those outreaches past the winter of 2020. And in late April, we made another presentation to the commissioners who indicated a willingness to move forward with a public hearing process as soon as the COVID-19 restrictions on public meetings were eased enough that they felt comfortable that the public could participate in this process. So basically, what we're really looking for is an investment in our community, a chance to advance. And the reality is that access or stigma, or there's a whole number of different factors related to accessing mental and behavioral health services in communities, in particular in rural communities. And we see that here. We see in relative terms the impacts in the emergency departments, on emergency services, and in our corrections facilities. And we heard countless stories about families who had trouble getting access for their children for services that were necessary, and in some cases those the outcomes of those were not what we would want as a community. So what we've got is a series of goals that we have presented to the community, to the commissioners, but also to the community in various forums. But our goals are to expand the delivery of on-site mental health screening, assessments, and treatment services to inmates. And this may strike some people as being, why would this be a focal point, for the community? And, to answer that question, it's a reasonable question. And the reality is that we see behavioral mental health services, visits to the emergency department, accessing emergency services, and potentially people who need to go through the correctional system as being all linked together, and they have a significant negative effect on the community, both in terms of risk to responders, to people who work in those industries, certainly to the people who are affected by these issues, their family, and just in general our community. And one of the easiest places, and I don't mean easiest because obviously there's a lot going on, but one of the places that a lot of communities have seen significant success in is if they invest in these services while people are going through the correction center, because not to trivialize this, but it's kind of a you have everybody's attention when they're there, and they have significant success in investing in those services. We also want to talk about transitional care coordination for patients that are discharged from the emergency room or crisis intervention. So people in our community who end up in a situation where they're in crisis and they've got a lot going on in their life, and it didn't get a lot better with an emergency room bill, potentially contact with law enforcement, and a healthcare crisis. They come out, and if we can connect them to the community services, then we can kind of set people back on a path to success. We want to expand the availability and accessibility of chemical and mental health crisis services in the community, in part by making them more efficient, but also in some cases we don't necessarily make those services available to all parts of our community, including young and old. And when we talk about access to services for youth, again, here's where statistically, if you look at the investment in behavioral and mental health services when the problems are relatively new and they're for kids, you get a huge return on investment in terms of positive outcomes. People who go on to work through those issues and then don't have those issues for the rest of their life. So again, more specifically, our goals are to expand the delivery and on-site mental health screening in the correction center. Again, this is shown to be significant decrease in recidivism. I hope I said that right. But basically people who return back through the correctional system. And if you ever want to be surprised by how much it costs, jail cost per inmate is a fairly significant cost, just in dollars, not to mention the negative impacts it has on the rest of the community and those families. Our second goal is these transitional care coordination services for patients that are discharged. Again, the emergency room, no offense to Dee Dee, who's on the line, is a wonderful place in terms of the quality of the care that you get there, but it is not a place to treat long-term chemical or behavioral or mental health issues. And it's sometimes those services are difficult to deliver in an environment where you have a lot of urgently sick people. So it can detract from their care as well. Our third goal in terms of emergency chemical dependency and mental health crisis, again, one of the things that we're finding is that we overwhelm our crisis responders in the emergency department. And by doing so, we actually negatively impact their ability to sort of do their day job during the week. And so we want to make that system more efficient by assisting them in providing those services. And finally, the fourth goal it has to do with screening and for children and youth for unmet behavioral and mental health services or health needs. The earlier you can catch these issues, again, very clear evidence that treated correctly, most of them get better with relatively easy as compared to allowing those issues to become more complex and exist for a longer period of time. So I've talked very quickly, I'm guessing, and now I'm actually going to introduce each of the panelists by name, and then they're going to just give a sort of a brief overview of how their workplace, how they're impacted by these issues in our community, and potentially maybe a little bit of information about the 110. So we'll start off with Dee Dee Utley, again with Kittitas Valley Healthcare.
Thank you, Rich. Again, my name is Dee Dee Utley, and I'm the nursing director of KVH's emergency department, and I also oversee our urgent care up in Cle Elum. I have close to 25 years of nursing experience, with the last 22 being in the emergency department. I've been here at Kittitas County Healthcare for 5 years now, and I've seen quite a lot of changes through my career. I first learned about the 1/10 of 1% initiative in early 2018 when I became a board member. on the Behavioral Health Recovery Advisory Board for our county commissioners. The proposal, there was actually a proposal written, as Rich had said, this has been decades in the making, and it was presented to the current commissioners at that time and sent back asking for more work to be done. Shortly after that, the Kittitas County Health Network formed, and I sit on two of those work groups. There is a behavioral health task force and an opioid task force. And a subgroup was born out of one of those groups, and here we are today. So the behavioral needs of the emergency department. As many of you know, our emergency departments are the safety net of the community. We are open 24/7, and by federal law, we do have to see everybody that comes in. We provide medical screening exams to make sure that there is not a life-threatening emergency happening. We care for all ages, all conditions, medical, trauma, acute, chronic, and unfortunately, behavioral health and substance use does fall into those. We work closely with many agencies. We're very fortunate in our community. We have wonderful EMS fire. We have a very tight relationship with our law enforcement agencies, and of course, comprehensive health care. The designated crisis responders, you'll hear us call them DCRs, those are the professionals that respond to the emergency department when people are here that need help. The patients are complex. They require a lot of resources, a lot of time. Our role here in the emergency department is to basically rule out medical conditions. We do lab work, we do diagnostics. We make sure that there's not a medical emergency that is causing the problem. We also will treat the substance use disorders as far as whether they are overdosing or withdrawing from medication or alcohol. During triage for all of our patients that present, we're also doing a very high level screening to make sure that they're safe at home, to make sure that there aren't mental health issues. Sometimes people come here for something that's not related to that, but we, by asking questions, are able to get them to the right resources. As I said, we're really fortunate to have great partners. The DCRs respond to the emergency department. Sometimes they're here before the patients actually arrive. Patients can come in, by just self-presenting. They can come in with law enforcement or through EMS. And again, I've worked in places where the DCRs are hours out, and I can tell you that we're very fortunate they walk through the door usually within 30 minutes or less. They then begin their work to decide what the final disposition will be on the patient. We are not going to do that long treatment. We're going to work with the DCRs. They're part of our care team. They many times have suggestions. They know these patients. They know what is in the best interest for them. They might work on a safety plan where they can go home and then be treated in an outpatient venue. Or unfortunately, at times, they do need further treatment in an inpatient psychiatric facility. Again, our role during that time is basically to keep the patients safe, to keep our staff safe, to keep our other patients and visitors, when they're allowed, safe. And we do know that this can be, again, very intensive. These patients can be very disruptive. Unfortunately, we do have violent events where law enforcement is required, and they are in our department for extremely long lengths of stay. So now when you throw in COVID-19, that picture has even become larger for us. We recognize that this pandemic is and will continue to affect many. The past few months have been difficult, I think, on the best of us. We have seen people that have been maintaining and doing well tip over the edge and require help and have to come in. And then the people who are already in a crisis, that crisis is even more expounded. A little bit about our department, Rich kind of touched on some of what I'm going to say. We're a 9-bed emergency department, but I would say we're not a typical ER. We have very high acuity of patients. So even when I give you a number, we don't have a lot of kind of that walking wounded in and out type of visits. Our patients are sick. So pre-COVID days, our emergency department averages about 38 to 40 patients a day. And I know that doesn't sound like a lot, but again, we do have a higher acuity than most emergency departments. we would average about 2 behavioral health or substance use patients a day. Now, not all of them require inpatient treatment and require that DCR to respond, but about 2 a day. So, and remember, I say average 2 a day, and that does not mean that they come in like every 12 hours like clockwork. There are times we will have 3 or 4 of them at once, and we might go a couple of days with none. So when COVID hit, the beginning of March, we did see our census drop a little that month. In March, our census dropped to about 33 a day. April, it dropped a little more, about 25 patients a day. And this drop was being seen across the country. I've talked to many of my peers, and everybody was reporting ED volumes, decreased by 40 to 50%. May, we jumped up to about 31 a day, and so far in June, we're actually up a little higher to 33 a day. So I can tell you our volume overall for the emergency department did drop, but what we are seeing is the patients that we are taking care of are definitely sicker. So whether they've delayed seeking care, not seeing their doctors, the whole what COVID is doing to us with the stay-at-home orders could be a part of it. But the other thing that's really important is even though our volume dropped, our behavioral health and substance use patients have not dropped. We are still averaging about 2 a day. And I can tell you that there's still, it's a different feel. I think our acuities are higher. We're definitely seeing lots of substance use disorders, whether it be the overdoses or the withdrawal. And then the length of stay. So these patients, again, I said that they were very resource intensive. And we do our medical rule out, but then they are here while that DCR is trying to find the placement or come up with the best plan for them. So our May average length of stay for our mental health, our behavioral health patients that needed inpatient treatment, so they needed to be transported to another facility for psychiatric care, the average was 11 and a half hours. We saw 23 patients in May, and the average length of stay was 11 and a half hours. And you can imagine if you've been in an emergency department room, that's a long time with not a lot going on. Our numbers also went up. I said we had 23 patients in May that we actually did have to transfer out. In March, it was only 9, and in April, it was 11. So also just to give you kind of a time of what a normal length of stay is in an emergency department, if you are a medical or trauma patient and you're gonna get to go home, we average around 2 hours. If you're gonna be admitted here at our hospital, it's about 4 hours. And if you're gonna be transferred to another facility for services that we can't give here, it's about 3 hours. So as you can see, 9-bed ER, a couple of patients a day, taking up a bed, taking up the resources. That is where Rich was saying, that those wait times can be impacted. So how I think that this funding, what I'm really excited about is, of course, if we can make our system stronger, our overall goal would be to keep patients out of crisis, keep them out of coming to the emergency department. But I do know that that's not realistic. I also love the idea of these warm handoffs. I think having more resources in our community and having us all at the table to talk, we are all in this together. I know Community Health of Central Washington has a great program. KVH, we now have a physician and a nurse that are specializing in addiction medicine. We work closely with Merit. We work closely with CWU. You're going to hear from one of my colleagues from Upper County who is doing some wonderful work with our behavioral health patients on an outpatient basis. And then lastly, the mental health assistant. This would be a position that comprehensive healthcare could hopefully have here. They do have it in Yakima County. It's a person that would help to assist that DCR when they're here in the emergency department, doing all of the work that it takes to find a bed for a patient. Even if the patient's going to go home, there's still a lot of work that goes into the interviewing and making sure that this patient's going to be safe if we send them home, or working on trying to find a bed. We're lucky if we can find a bed as close as Yakima. We do have a good connection there. However, sometimes we are sending patients to Chehalis, Spokane, and Seattle, and occasionally even out of state. So I think that mental health assistant would be just a huge help. As I said, these patients don't come in like one at a time. they come in multiple at a time. Sometimes we're admitting them, so there is also work to be done down in our ICU that this person could be assisting the DCR with. So I want to thank you for inviting me to be a part of this forum and share a little about what we do here in the emergency department. I think we're onto something great, and I'll look forward to any questions. Thank you.
Thank you, Dee Dee. Next up is Diane Rosso, who again is the Community Prevention and Wellness Coordinator for Ellsberg Schools. Diane, I think you have a presentation to work through as well.
Thank you, Rich. The Community Prevention and Wellness Initiative is a grant that is housed at the Ellsberg High School. And I've been under that grant for about 18 months now. The coalition that I work with is individuals from various community sectors. And together, we identified risk and protective factors that surround youth by analyzing data very specific to the Kittitas County. And that was through mediums like the Healthy Youth Survey, school district data, as well as local law enforcement data. The mission of the CPWI group is to prevent and reduce substance use and other potential behaviors in the Ellsberg School District students. So major initiatives that we work on, 0.1% is one of the major initiatives. And we also have a couple others of interest, that is the personalized education programs. If you could go ahead and go to the next slide, please. Personalized education program for students to be involved in a career choice with curricula that supports that choice, and then be tied through an internship with professionals in the community. We have put in permanent lock boxes for prescriptive opioids to be returned to. We hand out through pharmacies and locations like community, well, let's see, Merit hands out boxes. We have several places that are handing out consumer lock boxes for these prescriptive drugs so that the younger people aren't getting their hands on them. And we also have a social emotional learning curricula in the school district. So all these major initiatives to support the health of our youth. Why we're so interested in 0.1% is because we need more help in the school district. We need, with suicide being the 10th leading cause of death in the US, 8 in Washington and 7th in the Kittitas County, a lot of this is mental health issues that show up early that can be helped. Depression and anxiety are common, very common, and yet very treatable, and can occur along with substance use. So having additional support in the school district is what I'm most excited about as far as 0.1% passing, because I think we all agree that if we can catch these issues earlier down the line, they may not end up in the ED. They may not end up with law enforcement. They may be able to get the positive reinforcement and support they need to not enter the system. So increasing the mental health professionals in K through 12, identify earlier on with student assessments, providing them with individual and group counseling opportunities, and group therapies as well during school hours would be a major help to these students. That for me is the nutshell of why I stay so involved and so focused on this. Is I'm passionate for the kids. We work hard to engage them in education that is of interest to them, tie them to the community. We're striving to have our youth be positive members of our community. Thank you so much for having me here tonight.
Okay, thank you, Diane. Just to acknowledge, we're starting to get some questions coming through the chat line, and we very much want you to continue to put those questions. We do have time at the end of our presentations to go over them. We've gotten a question about the current system and its effectiveness, and then also about crisis lines. So acknowledging we're getting the questions, we are tracking those, and we will answer those at the end of the presentations. So thank you for engaging. Next up is Greg Abel, who again is the director at Comprehensive Healthcare. And Greg was a little bit challenged on his Zoom technology, so we'll see how this works.
Well, thank you, Rich. Hopefully everybody can hear me. I am the director of Comprehensive Healthcare here in Kittitas County, as Rich mentioned. I've worked in behavioral health care for Comprehensive in this county for 33 years. Many people, I think, in our community may not be aware of the services provided through Comprehensive that residents of our county are able to access and benefit from. We operate two 16-bed inpatient units in Yakima for adult psychiatric patients. We also have an inpatient children's unit. We operate here in Kittitas County 15 apartment units. We have an office up in Cle Elum, as well as an office here in Ellsberg. We operate a day support program. Most significantly, in terms of the 1/10 proposal, is our interaction with law enforcement and the emergency room. We have, well, first responders in general. We have a great deal of contact with the emergency room, our first responders, and the various law enforcement agencies throughout the county. I'd like to give everyone some statistics just to demonstrate the behavioral health need in our community. In the first 5 months of this year, there were 332 evaluations conducted by DCRs in this county. 240 of those occurred at the Kittitas Valley Hospital emergency room. That's 72%. So most of the time we end up at the emergency room. And as Dee Dee said, those contacts end up dragging on for a long time. So why is that? Why would it take so long to evaluate somebody and get them to the resources they need? Sometimes that includes transfer to an inpatient psychiatric hospital. Many times that includes developing a safety plan. The issue is that we have one DCR on call in our county at any given time. It's not uncommon for a DCR to be evaluating somebody at the request of the Washington State Patrol at the top of Snoqualmie Pass. And then the emergency room contacts us and says, we've got somebody to come, for you to come and evaluate. It's obviously going to take us time to get down there, and we have to try to wrap up what's going on with wherever we happen to be, whether that's Vantage, whether that's the top of Blewett Pass, whether that's Snoqualmie Pass. And believe me, while I'm not actively working as a DCR right now, I, for many, many years, took call as a DCR, and I'm very familiar with being up in Cle Elum in the middle of the night and then getting a call from the emergency room asking me to come down there or down to Ellsberg and evaluate a person in the emergency room. So to Dee Dee's point about mental health assistance, if we have mental health assistants that are working in the emergency room, they can begin that process while the DCR is trying to get to the emergency room. Or when we have multiple people in the emergency room, and that is also not uncommon at all. In fact, it's very common for us to have several people in the emergency room at any given time. The mental health assistant can be making the necessary contacts and assisting the DCR to reduce those long lengths of stay. One of the things that happens when we have a long length of stay like that is that, I don't know about any of you who may have been in an emergency room before as a patient, but if you're there for a long time, your stress level may start to go up. And if you're there for 10 or 11 hours and you've already gone in crisis, it's really difficult. And so the emergency room staff do their best, and they actually do an excellent job trying to help manage these situations. And the DCR tries to manage the situation also, but there are times where we need to call in law enforcement to assist because somebody will run out of the emergency room or somebody, a person being evaluated will get to a point where they engage in some kind of aggressive behavior. And as Dee Dee mentioned, law enforcement can then be tied up in the emergency room, and sometimes more than one officer can be tied up in the emergency room for several hours at a time. So of those 332 that we've evaluated so far in the first 5 months of the year, 264 were adults and 84 were children, which points to the need that Diane was speaking to. We certainly do see people in crisis at the jail. Most often, people that we see in crisis at the jail will end up getting transferred to the emergency room. The issue for behavioral health in this county is really a lack of resources. We have limited resources. In our county jail, we have a mental health therapist that goes in 10 hours a week. And we have a prescriber that goes in and works 2 to 3 hours a week. An example of how difficult it is to meet the need, pre-COVID, it was common for our prescriber to go to the jail and have requests by 30 inmates to be seen. And she would be able to see 6 of those inmates, meaning that the other 24 were not having their treatment needs met. Currently, COVID has decreased the number of people in the jail, but even with that decreased number of inmates in the jail, we still have a resource problem. It's regular now for our prescriber to see 6 inmates, review 6 other inmate charts, and then have at least 6 inmates that have submitted requests and cannot be seen. And when we're not able to provide the care to people in the jail, it puts the jail staff at risk. It increases the chance that once that person who didn't receive the treatment that should have been started for them, once they leave the jail, the chance is pretty significant that they're going to end up back in the jail. We have good evidence from other communities that shows that when we have these services in place, recidivism at jails decreases significantly. We also know that wait times or lengths of stay in emergency departments decrease when we have additional personnel to assist. And the cost to the residents of our county, when we have somebody, when we have 2 or 3 people that are in the emergency department for many hours at a time, is that just due to capacity, there may be people that present at the emergency room and have to be transferred to another facility out of our community because we don't have the availability to provide that treatment. So it's really in our interest as a community to be getting people to the treatment they need as soon as we possibly can. I would also mention that there is a measurement mechanism in place for this. The county commissioners have rightfully asked that there be evidence shown for the effectiveness of what we would do with this money. And the treatments or the programs that we're proposing are evidence-based. And so what do I mean by evidence-based? It means that we have data and evidence that has been gathered to show that these programs are effective. We are very fortunate living in a rural county in that comprehensive healthcare staff are trained much higher than the national average, in fact, very significantly higher than the national average in the provision of evidence-based treatments. We work with the University of Washington Department of Psychiatry, and we've also worked with Harvard University psychologists in becoming proficient in these treatments and effective in helping people recover from their behavioral health issues, and then be able to return into the community, be productive, and be able to contribute in a broad range of ways to the life and success of our community. So that is what I have to add. I look forward to responding to any questions that we have at the end of the presentation.
Okay, thank you, Greg. And just to acknowledge, we are still getting really good questions. Another one came up about timeline, so we're getting these questions, and we'll get to them shortly. The next panelist is Oren O'Connell, who represents a bit of a success for our community. We were able to convince him to come and work in our county as a family psychiatric provider. So Oren, did you have a presentation?
Hey, good evening, everyone. First off, let me know if you can't hear me okay. I'm connected via my phone, should be all right. So I want to share a little bit as a family psychiatric mental health nurse practitioner, but I also want to share as a citizen and try to keep this as practical as possible. I'm just going to be talking for 5 to 7 minutes and giving you my thoughts on this proposal. I work with Kittitas Valley Healthcare since 2017 up in Cle Elum. We're building a collaborative care model where I'm the psychiatric consultant supporting the primary care providers, and we also have a behavioral health care manager who is a social worker. So that program is in the infant stages and getting up and running, and I think it's going to be a huge asset to our community. Additionally, I've been employed with comprehensive health care actually since 2009. I started out in the trenches as a mental health worker, eventually got my RN, then my doctorate as a psychiatric nurse practitioner, but I still work for comprehensive in Yakima, occasionally on weekends in the inpatient units, and I worked with Greg before, had that honor. I filled in for Jamie when she was on maternity leave. I think that was in 2017, and I actually covered at the jail as well. So I've had a broad experience of our county. And what I can say is I feel very strongly that we're doing some good things, yet people are still falling through the cracks. Families are falling through the cracks, and they're feeling those effects. And our DCRs are very effective at intervening in a crisis. Now, the issue is there's a gray zone there because there's specific state laws that those DCRs are limited by on how they can help someone. And, that's a matter of civil rights. And so there's this gray area when somebody isn't attainable, or, say they are a frequent presenter to the ED, and we have challenges, there is a lack of resources. So when we say a lack of resources, I really feel that we have a lack of care coordination, and that is among healthcare, that's among, our county jail, and that's what I think this initiative is really going to be an asset in moving us forward in from a population-based perspective. And within that, there's a few principles I want to share. Greg had talked about evidence-based interventions. Comprehensive is very good at leveraging those. We at KVH are also constantly reviewing the literature and trying to grow as a community and providing evidence-based interventions because we need to learn and grow. And one of the challenges here that the commissioners have asked is they want data, they want accountability. I think accountability is great, but if you really had the data to show, what leads to recidivism, somebody being reincarcerated, repeat offenders, if you really had good data on that, you'd probably win the Nobel Prize in medicine because there's not a whole lot of data out there. We do know what fuels a lot of this with frequent ED visits, patients falling through the cracks, repeat offenders. And that are things such as adverse childhood experiences, having a parent who's gone to jail, having a parent who's had a mental illness, having a parent who's had an alcohol problem. Those are all things that we want to address, right, in providing better coordination, that those individuals can get the care that they need from a, I like to say, holistic perspective, but these individuals are falling through the cracks. And even within law enforcement, there's an estimate within cities that 10% of all law enforcement calls are mental health related. And I think it's actually much higher in rural areas. So we have to really keep in mind here that a lot of this is going to be just-in-time learning. There's going to need to be pivots as we gather data, as we move along. One of the things that I don't want to see happen is I don't want to see Kittitas County fall behind. Initiative was passed in Yakima, passed in King County, and one of the things you're actually starting to see, because we were just in a hiring process for a behavioral healthcare manager, is you are seeing counties and the state leveraging money and funds, and we have a limited professional pool. So the longer we wait on this, the harder it's going to be to get individuals in key positions where we need care coordinators, or we need additional counselors. So we need to move on this fast. I don't know the exact timeline, but something else I can share that I've been following is COVID has complicated everything. And right now we've seen a drop, across healthcare. My numbers have actually picked up quite a bit, but we have seen a drop within the ED, within primary care, because people are staying home and they are putting off getting medical care. But one of the things we know from quarantines, and we have this from studies in 2003, 2004 from SARS, is that about 6 months to a year later, we see a big swarm in the mental health system, because actually after quarantines, depression cases rise and PTSD. And it's just the nature of what happens. We don't know what trauma may or may not be happening, with kids who are, in tough families who don't have that respite at school, who don't have that outlet. So, I speak to this issue as a concerned citizen, and my chief ambition and frustration as a psychiatric provider in our community is that there is a lack of care coordination. And that's not just within Kittitas County. This is a national issue. And it, stems from, first responders deal with this, to comprehensive with community mental health. So that is my main ambition as far as, being an advocate for families and patients and ensuring that people do not fall through the cracks.
Thank you, Oren. Just as a reminder, we're still getting questions coming in, and any questions that we don't get answered on air before 8 o'clock this evening will be answered on the Facebook page. So we will get answers to all of your questions. Our last panelist is Steve Panatoni. So Steve.
Good evening. How are we doing? Great. I've been in law enforcement with Kittitas County for 38 years. I started out in the jail back in 1982, and I worked there for 3 years. Then I went to the line and patrolled the county roads in Kittitas County for the last 35. During that time period, I have seen a lot of crime. I've seen a lot of domestic violence. I've seen property crimes. I've seen assaults. I've seen child abuse. I've seen a lot. And a lot of those crimes have been affected by substance abuse or mental health. From the law enforcement perspective, our hands get tied when we deal with certain issues relating to mental health and substance abuse when we can't just arrest our way out of the problem. Just a couple examples of that. We have people that have a substance abuse problem. They've been involved in multiple domestic violences. We respond out there. One day, the wife may be the victim. A week later, maybe the husband is now the victim, but it's not because she did something wrong. It's simply because that she got the upper hand on him that one time. It puts law enforcement in a predicament of who goes to jail. How do we fix these people? You take somebody to jail. You cannot fix mental health when you stick somebody in a concrete box. Like Greg said earlier, you take them to the ER and they stay in there for 3 hours and it raises their stress level. Imagine what's happening at the jail. And this affects the kids. This affects how they perform at school. This affects their friendship with other kids. This affects your neighborhood. This affects your parents. This is a big deal. Anyway, so during that time, I've seen a lot on the street. 2 years ago, I was given the opportunity to run the jail, come in, provide some leadership. One of the first questions I asked was, what are we not doing that we could be doing? And just looking at, what's going on in the state, the substance abuse, there's drugs that meth, marijuana, heroin, all over the years. Now we're into fentanyl, kind of a fad deal. But what are we doing for these people? I mean, we've been in the law enforcement business for forever. We've been in the corrections business forever. We've been in the medical business forever. If we want a different outcome, we got to do something different. It's just simple like that. So we examined, what our programming was. What can we do to either lower our barriers or take a different look at how things are working here? What services can we provide? What services are we providing that are actually making an impact to the community? So we fully fund as much as we can afford and as much as comprehensive mental health can supply in Kittitas County to get our folks in here the counseling they need, get them on the right track, and provide those services that sometimes they're just not able to focus on when they're out in the real world with the actual stressors of the real world. Same thing with the substance abuse thing. When folks come in here, they need to be detoxed with a medically assisted treatment that we have employed with the help of KVH and community health. We're able to lessen the effects of that detox in our facility. It makes it safer for our employees. It makes a lot better experience for the individual going through it. It reduces the effects of having to take somebody to the emergency room all the time, and it saves resources from the EMS coming to the jail to pick the guy up and take him down there. So we're doing some things right. When we start talking about substance abuse, this is all voluntary. I saw a question on the forum there that says, forced treatment, so on and so forth. We don't force anybody to do anything, but we certainly make it available that if they want to talk and they want to hand up, we are here to help them out. There's a lot of folks and agencies and stuff that have offered handouts over the years, we offer hand-ups. It's not cheap. We are doing what we can afford right now. It would be fantastic to have sustained funding for these programs and to be able to expand these programs in the future. But get back on track a little bit here with the substance abuse. There's a couple flagships in the state of Washington that other agencies have kind of got going. One of the flagships was Benton County, and they employed a process where they basically take the individual from the time he comes in, volunteers for service, provide service all through the time he's incarcerated, hand him off to an outside entity when he leaves the facility, and then carries with them, 30, 60, 90 days, whatever it takes to keep them going forward. They have experienced a 70% reduction in recidivism in their jail. That is crazy. Now, this is a 1 or 2 year number. So what are we going to do? Look at it 5 years down the road. Snohomish County, some of the folks on the coast over there, again, flagship stuff, 1,302 individuals involved in their program, 6% came back to jail. I mean, that's a huge cost savings. It's not cheap to put people in jail. And you think, oh, geez, it costs $63 a day to throw somebody in jail. Well, it doesn't when they need $10,000 worth of medical care, or they need, $5,000 worth of dental. That's all being paid through the county. And so it is really expensive. And so our focus is simply this, is what can we do while they're here to give them a hand up, get them out the door to services that will carry on for the next few months, to get them back on their feet and get them to be a productive member of society. If we can do that, and we can, not change their habit, but help form a new habit in their life and get them on the right track, it takes the stress off the family. It takes the stress off the kids. It's a ripple effect. You're going to see it in the stores. You're going to see it in your neighborhood. You're going to see it in the school. It's big. And honestly, it's measurable. We know what numbers come in the jail, and we know which ones go out of the jail. And so it's something that we can look at, tweak, but it's very exciting to be able to be a part of something that we can build and build for the community. This isn't a selfish thing. This just involves everybody that we're talking about that lives here in Washington State, not only Kittitas County, but Washington State. I've got a lot of travelers that come through. They get in trouble. They come to jail. What are we going to do? Well, let's give them those same services. Let's give them the ability to better themselves. So when they leave here, we can connect them with their services in Pierce County. And we do not give them the break in time from the day they exit the jail until they have time to think about things and go down the wrong path. The mortality rate of somebody that is on substance abuse, and if they're going to die, it's going to be within 14 days after they get out of jail, because they knew they took this much product when they went into jail and it treated them fine. They get out of jail, they're clean, they go back to the same amount of the product, boom, they die. So there's a lot of evidence-based stuff. We're not making this stuff up. It's working. It's just getting the opportunity to get the resources in place, get this well-funded, get sustained funding for it. And once this machine is built, like I said, it was meth, then heroin, then fentanyl. I don't know what it's going to be tomorrow or 2 days down or 2 years from now. We do know that these drugs clearly have an effect on the mental ability of people. And so whether it's just a substance abuse thing, we're seeing more and more dual diagnosis. And that's what your comprehensive mental folks can talk about here. But this isn't a fix, a 60-day fix. These folks need help for 2 years to reprogram their brain and to get back on track. But we've got to do something different than we're doing today. If we don't, we're just going to be in the same spot, doing the same thing, arresting the same people every week, bringing them to jail, not fixing anything. and I am very passionate about this. And frankly, feel free to call me at any time. I'll certainly answer what questions we got. But we're here. The building is here. We're going to be in the corrections business for a long time. Let's make the most of it. Let's get folks in our community back on the right track. Let's make better neighbors. So thanks, Rich.
Thank you, Steve. So I wanted to catch up with the questions that we've had. We do have time to answer those. There was an item on my agenda that was to talk about sort of where this money is going to go, and a couple of the questions that have come across the chat board have had to do with funding. And so just to talk about the distribution of funds, if this tax is passed, they would begin collecting money in late 2020, and the pool of money probably wouldn't be available towards the end of 2020 or the start of 2021. The advantage to passing the tax, though, is that essentially the grant programs, both state and federal, one of the first things they look at in a local community is what investment is the local community making. And we are at a profound disadvantage for matching funds. I mean, granted, this money is our communities. We send it out to the state, we send it out to the federal government. We're trying to get some of that money back to reinvest in the community. But absent our community's demonstrated willingness to invest in solutions in our community, we're at a disadvantage. So just by virtue of passing the tax, we'll suddenly become much more competitive in the process for application for these funds. But somebody asked the question about when the money would become available. How are the funds distributed? The funds are distributed as approved by the county commissioners. There are elected officials who control the dispersion. We've talked about different models to help them make these decisions, whether that be an advisory group, but ultimately the 3 county commissioners, therefore 2 of the 3 county commissioners have to vote in support of funding an initiative. The funding itself is fairly limited in scope to new or expanded programs directly related to mental and behavioral health services. The programs that we've put in front of them as things that we believe will have the highest return on investment, in other words, potentially have savings in other areas of government or in other community areas, or produce the highest number or impact back to the community in positive terms, is the correction center spending. Estimated cost for that program is about $300,000. The care coordination services for the ED is about $150,000. And the expanded availability and accessibility to emergency chemical dependency and mental health crisis services, helping out the DCRs and the emergency department, is roughly $200,000. And then there is a fairly significant amount of funding proposed for the youth services to catch these problems a little bit earlier. And I'm going to kind of come back and try to tie a couple of other questions that we received. And if any of the other panelists want to speak up, can, or if the people that submitted these questions feel like I'm looping their questions together. We received 3 questions that sort of relate to each other, actually 4 that sort of relate to each other. And they all have to do with sort of that concept that, hey, what we're doing may have a significant impact on human rights. These programs may not have the level of effectiveness that we want them to have. And one person noted that when they accessed like crisis line services, that it didn't work for them. And I think if we back up a couple steps, this funding is about investing further upstream. It's the difference, and again, no offense to Dee Dee when I say this, but you know, one of the most costly forms of healthcare is the emergency department. And if people use that as their primary healthcare, if they don't access you know, they don't take care of themselves and they don't have access to preventative medicine and regularly see their own providers, we see statistics that say that you know, seeking care in the emergency department actually costs roughly 10 times what it would cost if they would access healthcare. Now that assumes that they have those options. We're really talking about that. So when we talk about effectiveness, when we talk about, you know, potentially holding people, you know, against their will, or making decisions about custodies and those types of things, which are all potential negative outcomes for behavioral and mental health services, that isn't what we're talking about is catching these problems earlier in the system when people have more choices, when the opportunity for them to maybe not eliminate some of their choices or end up in a place where they can't leave for a period of time, it isn't taken away from them. And so this is about investing in our community. And I also want to talk a little bit about the issue related to how this funding works. All taxes, are controversial, and there may be some people out there who like them. I'm not one of them. However, I work for your tax money, so my job is to give you your money's worth. And in the case of a 0.1% sales tax, I think it was crafted this way for a reason by the legislature. They don't always make good decisions or decisions that everybody agrees with. But a sales tax, particularly in a county like Kittitas, where a substantial portion of the sales tax is actually paid by people who don't live here, in many cases are simply traveling through the community. That's a substantial percentage. So for every dollar of tax revenue generated in this county through this tax, a significant portion was paid by people who don't live here. And so that's something you're getting a little bit higher return on your investment versus, say, a property tax, which is paid for entirely by people inside this community. So again, we still have about a little more than 15 minutes, and I did see a question about timeline and had to do with schools. And so, Diane, I don't know if you want to unmute, but it had to basically, the question was basically, hey, the impacts of school closures and the disruptions to the education system as we come back online, the funding's not necessarily going to be there. And what are, sort of what's the outcomes? I don't know if I'm stating that well enough, but I don't know if you can answer that.
Pre-COVID, we were seeing an uptick in the need for behavioral health support in the elementary. All of us that are at the district are extremely concerned about what happens, how we go back to school, what it looks like when we go back to school. Is it a full-time school? Is it part-time school? All of these decisions impact the kids dramatically. But everyone is anxious about the need for them to get back into a normal environment away from their home environment. If we can do that, right? If we can do that safely, of course. And I think your question is, when will the money make an impact? Is that you're on mute.
I'm going to back up to the question. And so this was a question from Jerry. The consequences of school closures are likely to be significant with regard to mental and behavioral health for students as schools transition through the upcoming year, given the continuation of the pandemic. What would be the time frame additional funding would come available? And we kind of answered that. But also, I guess that frames the question. And so I think it has something to do with, hey, we see this potential wave coming in our youth.
Right.
And, are we going to be able to catch up to this?
Right. So a big issue for us was we were already insufficient in this kind of support for our students pre-COVID. We can't get the money fast enough to help. But what we have done, not even knowing COVID was going to hit us, was things like, for the older kids, the personalized education program, where we are working to engage the students in a curricula that they are interested in. We match, you yourself have signed up, and we so appreciate you, Rich, to take a student, to show them what it's like to live in your shoes for a certain number of hours during a quarter. So they'll study about being, working in a fire department because that's what they think they want to do. And then they get paired with you, an expert, to really understand what your days look like. We've worked with even further upstream where maybe parents or an older sibling are on a prescriptive opioid for a an injury in a sport, and we want to make sure that they're locked up. So we've tried to put in additional programs to kind of go upstream and try to prevent some of these things. But the bottom line is, when they get to high school, social emotional learning curricula, we're very involved in putting that down in the grade schools right now to try to help expand the programs that they have, so that they start getting a consistent, positive message and tools from how to manage and handle their emotions as they're growing up and going through their chaotic times. But we need more people that can work with them one-on-one, that can intervene and take them into a situation where they can really support the student. We have had one mental health counselor for students that was split between 5 buildings. So the high school had this individual for maybe 6 hours a week. I could be wrong, Greg, you might know more about the number of hours we had him, but it wasn't enough. And again, with this uptick in the elementary school, it's got us all concerned about that. So we need more errands on the ground to help us out with students at that boiling point, right at that time of need.
So one of the other questions came through and essentially talked about self-funding taxes, and how do you make that make sense to people in the community who may not see a direct negative effect. And I can answer this sort of from a community perspective. And you look at communities that are really struggling, their livabilities are going down because they're sort of overrun with these issues, and businesses, major businesses, international businesses, start to look at their decision to be able to locate in those communities. And so I think that there's an overall economic impact by not, managing these problems in our community, aside from, the fact that we need to take care of our own. But the big piece here is that one of the groups that we presented to was the Kittitas County Chamber. That's business community. It's not all businesses, but many of the business community. And we have a unanimous recommendation to support this from the very businesses who have to charge a sales tax on their services and their goods. And that's telling, because I think they recognize, the negative impacts that potentially have mental and behavioral health, both on their employees, their customers, and other community members. It impacts their ability to do business, and they're obviously invested in this community. Just a quick statistic, and then I'll move on to the next question and a quick story. Just so you guys understand this, EMS and fire, this is Kittitas Valley Fire and Rescue, we do about 2/3 of the county geographically for EMS response. We're running an average of one specifically behavioral or mental health call for services each day. And so those are volatile calls. They tend to be the ones that are more dangerous to the providers. And I also want to sort of emphasize that one that we do, multiply that for the mental health workers, and particularly law enforcement, corrections, and the emergency department. We're seeing a small percentage of what they say. That collective risk to the community and to the people that we ask, that we employ in this community to keep us safe and to provide these services, that has value to it. And doing things that can reduce, those incidents of crisis is exactly what we're looking to do, because those incidents of crisis sometimes have very negative outcomes. We have responders, we have members of the community, families, and the people themselves are hurt. I just wanted to quickly say, to describe the situation, that the reason that I sort of became very directly involved in this about 3.5 years ago. We had a family who the system failed them. This was a military family. They had a 14-year-old child. The 14-year-old had some, very diagnosed, very treatable issues, mental health issues. And the family was a military family and had TRICARE insurance. And because of the way referrals work outside of counties and the lack of services available for essentially an adolescent patient in our community, they weren't able to access services except they were able to drive up north of Wenatchee. And that wasn't always possible given deployments for one of the family members. And anyway, this child fell through the cracks and ended up with a permanent impact from a prescription drug overdose that was available, they accessed in their own home. And talked to the parents, and they were passionate about this. And it just, we can't, I mean, this is a military family. They had insurance. They were trying to do all the right things, all of those things, that you can kind of tick away and say, these are people that are doing everything that they're supposed to do. And we couldn't help them help themselves, and, with permanent consequences. And to me, I find that unacceptable. So I've got up here, I'm just going to kind of back up on the question list here because I got a little behind. Somebody just said, kind of confirmed, initiating the self-funding makes it more likely we'll receive additional funding from outside sources. That's an emphatic yes. The first box that's checked is they ask if you've passed the 1/10 of 1%. That came from Tio. And then we've got, could services be delivered virtually in terms of, kids are getting educated at home? Could some of these services be delivered virtually? I would defer to, Diane on that. I mean, obviously we do it, but I don't know that it's as effective. And
we're actually working right now to put a group for small groups for students in place with comprehensive health care for the summer months, to try to help do that, and that will all be on teleservices. So we're working right now to initiate that program. Yes.
Oren, do you have anything on that? This is your deal too.
Excuse me, I operate within KVH. So I've gone primarily to virtual meetings. So, we're doing it. We've been doing Zoom from the beginning, or pretty early on, I should say. So yes, I am doing virtual meetings. That barrier is not there. Directly, with the schools, my process is a little bit more unique because somebody has to go through their primary care provider first, and then they get a referral to me.
Okay, so we had another question talked about basically saying thank you for making the proposal, and how can we help? Anybody that is watching this, we just ask that you make people aware of it. We realize some people are not going to be in support of that, and that's a very valid point. Whatever your opinion of this presentation or things that we could do to make this better, we would like to hear about it, but also I believe the 3 county commissioners should hear about it. Even if that's, that you don't support this, we want, we want the commissioners to have heard from the community in a way that tells them that, the community knows about this and here's what their opinion is, here's how they'd like them to vote. Additional question here talks about programs that we could support locally that are designed specifically for youth and adolescents who are struggling with drug abuse or at higher risk. And it ties into what Steve said, but I'm thinking this is really, Diane and Oren again, and maybe Greg, maybe Dee Dee's aware of it. So we're talking specifically about programs for sort of diversion or avoiding drug abuse and drug use with younger people.
So working with Youth Services of Kittitas County, trying to get some programs going. They've already started planning once a month outings for groups of students that are drug-free outings. For the school district, we're working with them to have leadership groups that are tied to the personalized education program. And they have other initiatives that they're working on as well. So I think us being very coordinated with the youth services is going to be helpful. The other thing I'd like to say is the grant that I worked under, the Community Prevention and Wellness Initiative, is always, we are trying to work upstream to help prevent the this use. They're the ones that suggested heavily that I get involved in 0.1%. So this goes back to the question about will we get additional funding? And you said adamantly yes. I second that, because being part of CPWI and helping to get this 0.1% through helps ensure that we get additional CPWI funding in the future, and it makes much more available additional federal grants and state grants for us. You're on mute.
Sorry.
So this is Oren.
Go ahead, Oren.
So there are some services. I know Merit, right, has some services for youth as well. I work with a number of youth. I work with, from kindergarten all the way to end of life. But there was a question that I wanted to address, and I think Greg could speak to this well too. And I can speak from the standpoint of psychiatry, and it was talking about this idea of treatment not being effective. And what I can tell you though is that when somebody meets with me regularly, the data show, and in my experience, about 70 to 80% of individuals do get better. And what we mean by better is somebody comes in with depression, we treat them 3 months later, they're out of the depression, they're in what we call remission, and then 2 years go by and there's no more depression, and that's considered a success rate. There is a pool of anywhere from 10 to 30% of individuals who do not respond to psychiatric interventions, whether that's non-medication or medication. And that's been my experience. One of the other issues, there's the Pareto principle, and this applies across the board in our county, in that there's a pool of about 10 to 20% of individuals who make up 80% of the burden on healthcare, ED, first responders. These are people who are like a revolving door, and it's a lot of times even generational. So this initiative, and I am very excited about the care coordination piece. I'm also excited about the substance abuse treatment, mental health interventions in the jail. And my conceptualization has been that a lot of this money will be used to hire behavioral health professionals who are going to provide those interventions. So that's a big deal. But what I will say to treatments not being effective is treatments are quite effective. What's not happening is compliance. And I'm about a month to 2 months out. Now I'm starting to become 3 months out with appointments. So if somebody misses their appointment, I make sure we give them at least 1 or 2 calls. But if we can't get a hold of somebody after 1 or 2 calls, then the ball is in their court. And unfortunately, this is something we're working on. People do fall through the cracks, and it's an issue. And we, unfortunately, I know Comprehensive has policies in place, and they try to be very lenient about this. But if you no-show half a dozen times, you're going to get discharged from services. But what we need is somebody who can be more proactive and saying, hey, what's the barrier here? What's going on? How can we get you into counseling, when you're discharged from the ED or from jail? How can I help you? We want to build that therapeutic alliance, because when that therapeutic alliance exists, interventions are actually quite effective.
Okay. All right. So we're coming up on 8 o'clock, and I just wanted to answer a couple quick questions and just remind people our understanding is the timeline is the county commissioners are going to entertain a public hearing. Hopefully the county will move into phase 3, and that will be at least partially in person in the first part of July. And our hope is that the county commissioners will, as a result of that public hearing and all of the input they've got, that they will choose to hold a vote and have that finished by the end of July. So the public hearing is a component of this. And then somebody else asked the question about, is this a public vote or vote of the commissioners? The way the law is structured, it is intended to be a vote of the commissioners or a councilmatic action, and but they do have the option to refer it back to the community for an advisory vote, with obviously a cost and no guarantee that they would necessarily do what the public says or not says. And I don't know what they will do with that decision. That's a decision they're making. But as it stands right now, we we sort of optimistically hope for a public hearing in the first part of July that will be well advertised. We've come up on, is your plan to recruit mental health professionals? Absolutely, there is a massive shortage in the county. Mental health professionals would be part of the outcome of the pool of money. So we've come up on 8 o'clock, which means I guess the recording stops and the link to Facebook stops. We will still continue to take questions through Facebook, and we will get them answered. All 5 of the panelists here are, including and the 6th myself, we're 100%. You know, we may not answer the phone the first time because we may be doing other work, but we're available to answer questions. We work for you. We work for this community. We're heavily invested. So if you have questions, you can contact us either through the League of Women Voters, who I'd like to thank for hosting this forum. And obviously you can contact us directly through the agencies that we work for.